Welcome everyone to the fourth webinar in the 2021 Virtual Chordoma Community Conference series. I am Shannon Lozinsky, Director of Patient Services at the Chordoma Foundation. I will be moderating today's webinar. We are glad to be able to host this virtual conference series this year in place of an in-person event, but we are also really looking forward to the possibility of having an in-person event next year. So far in the series, we have had webinars on pain management and cancer-related fatigue, as well as an Ask the Experts Q&A panel where we talked about all things chordoma related. You can find recordings of those webinars in the webinar library on our website, chordoma.org. Today, we'll be talking about regaining balance, strength, and mobility after you've been treated for chordoma. When we say mobility, we're talking about the ability to move about freely in your environment. And as many of you know, chordoma tumors and their treatments can often cause side effects that affect mobility, such as balance impairment, neuropathy, which causes tingling, numbness and pain in the arms, hands, legs, and feet, bone fractures, and even some types of vision issues. So our goal for the webinar today is to help you learn more about these side effects, what causes them, and what can help you manage them and how to access that care. So with that, I would like to welcome and introduce our speakers. Dr. Lisa Ruppert is a doctor of physical medicine and rehabilitation at Memorial Sloan Kettering Cancer Center in New York. She specializes in caring for cancer patients and survivors who have neurological impairments caused by tumors of the spine, spinal cord, and brain, or resulting from treatment from those tumors. Her goal as a physiatrist is to optimize her patients' functioning and improve their overall quality of life. And Dr. Justin Brown is the director of reconstructive neurosurgery at Massachusetts General Hospital, as well as the founder and director of the Paralysis Center there. His practice of reconstructive neurosurgery focuses on restoring movement following trauma and paralyzing injuries. His goal is to repair nerves, optimize patients' functioning, and help them recover movement in their extremities. We are so happy to have you both with us. Dr. Ruppert, you'll be leading us off, so I'll turn it over to you.
Thank you, Shannon. I'm just gonna get ready to screen. Thank you for having us today. Hope this is a very insightful presentation for everyone. So I just want to state that I have no financial disclosures, so just wanted to make sure that I put that out there first. So I think when we talk about mobility and the factors that play into any kind of impairments, I think it's important to start with where chordomas are found and what structures are in those areas. So chordomas occur in the bones of the skull base and in the spine. When we talk about the skull base, we're talking about the clivus. The cervical spine is our neck area, the thoracic spine, so our chest, the lumbar spine, the lower part of our back, the lower part of our abdomen, and then our sacral spine and our coccygeal area, which would be our pelvis and a little portion of our lower back. So what does that mean in terms of the structures that are there? Well, when we think about a skull base, we're thinking about structures near the brainstem, any of the cranial nerves that coming off in that area or running course there. We also have to think fairly up high about our spinal cord, the connection where our spinal cord and our brain do meet, and some of the impairments that we can see from that. If you think about it and you look fairly up high, even up higher in the cervical spine, we're talking about sensation to the back of our head, to our neck area, our shoulders. We start to talk about muscles of the arms. So those that are going to bring our arms to us, to our face, allow us to expand our arms out to experience our environment, our hand function. When we move down into the thoracic area, we're thinking about the muscles that control our trunk, allow us to be stable in an upright sitting or standing positioning, and even when we're walking. And then we start to move down into the lumbar part of our spine. These are going to be the muscles that move our legs. So our ability to flex our hips, extend our knees, lift our ankles, all the movements that we need in terms of walking, also movements that we need in terms of transferring. And then when we get down to the very bottom, for the most part, a lot of times when we talk about the sacral chordomas, we're thinking more about bowel and bladder. but the S1 nerve root does come off here too, and it does play a role in terms of our leg movements and when we're walking. So what do these mean? If we have any of the cranial nerves impacting our vision, if those are impaired, we might experience loss of vision, double vision. Because of this loss of vision and double vision, it may be very hard to orient yourself in your environment. So you may have balance impairments and also nausea. And that's a big thing when you're thinking about transfers, when you're thinking about walking, any kind of symptoms that might impact that. So these impairments, our ability to move about our bed, to know the diameters of our bed, where we're moving, what obstacles might be in our way, our ability to transfer, what surface are we transferring to? Do we use an assistive device that we need to see to be able to reach? Walking, negotiating our environment, using adaptive equipment. What kind of vision do we need in terms of bringing our adaptive equipment, putting it on, being able to manipulate it, and the ability to safely operate a wheelchair. When we're introducing something like a wheelchair, now there's an extra piece in our environment that we're having to negotiate. Weakness. When we're thinking about weakness, we're thinking about primarily our upper and lower extremities, but we also have to think about our trunk. Similar to vision impairments, if we have trouble moving our arms or our legs, it's going to impact our ability to move in bed. And when we think about bed, it's not just rolling, our ability to sit up and get up to the edge of the bed, our ability to transfer from different surfaces, walking, again, ability to use adaptive equipment, and our ability to operate a wheelchair. Shannon nicely started to talk about some of the sensory impairments that you may experience, whether it be from peripheral nerves or neuropathies from different treatment. But also remember, those nerves that are leaving the spinal cord not only carry motor function, so the function of our arms and legs in terms of movement, but our sensory awareness to where we are in space and what we're touching. This is big because it also impacts our balance quite a bit, our ability to know where our joints are. In addition to the bed mobility, the transfers, sensory impairments may result in pain, and that in itself might have a negative impact on our mobility. And also we have to think about surfaces that we're sitting on, we're standing on, or any kind of bracing that we may be using. If we don't have good sensory awareness to our skin, we have to think about skin breakdown and making sure that we're protecting it. Why present it this way? I think sometimes when providers speak, we start talking about the impairments that you have, but maybe we're not always on the same page about what that means. So if you can start to think about stuff that you're struggling with and maybe why you're struggling with it, it'll help your provider understand how better to assist you or really to understand where things are coming from. In addition to the nervous system type of impacts, again, Shannon nicely talked about the different bone involvement. So what types of things can we see? If we're talking about the spine, we might be talking about abnormal curvature. So scoliosis, kind of an S or a C-shaped curvature to the spine. Hyphosis, that means when we always think about the hunch over that you may see when someone gets older. But that is, a big thing that might impact us in terms of pain. And also if we are hunched over, that means our head is forward. And if our head is forward, gravity wants to pull our head to the ground. So that can have a really big negative impact on our balance. How is our pelvis moving? This is important for a number of reasons, not just from pain, but it's going to impact how we're sitting, where there is pressure on a surface that we're sitting on. And also it may impact how long our legs may be. So in other words, you may not have a true leg length discrepancy where the legs are actually two different lengths, but a functional one. So depending on how you're sitting or standing, one leg may be perceived as shorter than the other, and that could impact how you're walking. We also have to think about any kind of surgical resections that may have happened and what that means in terms of use of an extremity or weight bearing or even onto the spine. So skeletal abnormalities do cause us to have abnormal postures. They may cause us to have abnormal movements, and they're going to impact our ability to bear weight on our arms, our legs, and also in terms of our spine. Similar to the neuro impairments, they impact all the different aspects of mobility, and they're something that we really need to take into account. So when I evaluate a patient, I'm part of the team, and I'm a firm believer of the multidisciplinary team that takes care of our patients, and particularly our chordoma patients. We're all in this together, and I think the important part to remember is you are part of the team. So yes, you have a group of physicians and perhaps therapists and other individuals who are helping, but you always need to be at the center of that team. In addition to you and your loved ones, We think about the neuro-oncologist who may be caring for you, any medical or radiation oncologist, your spine surgeon, whether it be a neurosurgeon or an orthopedic spine surgeon, surgeons who may have taken care of any other bones in the body, so more of the orthopedic side, physiatrists, which is what I am, pain and palliative care specialists, might have an ophthalmologist who's on board if there is vision impairments, physical and occupational therapists in terms of coordinating different type of activities that we may be doing and addressing our needs, certified prosthetist orthotist. And I don't know that this is always someone that everyone thinks about, but these are the people who can actually help us with bracing. So a type of adaptive equipment that can help you improve your mobility. And another person that oftentimes not everyone thinks about or is not even actually sure of what they're called is an assistive technology professional or a certified rehabilitation technology supplier. So these are the providers that can assist us kind of canes or walkers, any kind of wheelchairs or other adaptive equipment that you may need that's beyond just bracing. So it's really important that all of these members are in communication with each other and that we're in communication with you because we want to know what your goals are and we want to make sure that we're meeting all of your needs. Oops. All right, press the button too many times. So when I'm evaluating a patient and when most providers are, there's different components that we're going to look at. So first, your history of present illness, what this is, what brought you to see me today, what are you experiencing? And we take into account a bit of your past medical history. So those aspects of your treatment for your chordoma that may be impacting the symptoms that have brought you, whether it be surgeries or radiation or any kind of systemic treatments. What other medical history do you have? What else are you bringing to the table outside of just your chordoma? And how is that impacting? Or how do I have to take that into account? What type of medications are you taking? Are you taking things for pain? Are you taking things that might be sedating, impacting your blood pressure in any way? Important to know these things so that I could really make a comprehensive plan for you. Not only do I want to know how you're functioning now, I want to know how you functioned prior to your treatment. So I could really understand where the change was, what has changed, and what goals you may have in terms of bringing you back to the things that you want to and need to be doing. And who is your support system, both just directly in your home and in your community, because they're going to play an important role in any decisions that we make. Exam. Bring it back to those early slides where we talked about where the chordoma was and what structures are involved. We always start, we're going to check your muscle strength. And when you see key and non-key, what the key muscles are those that are geared specifically towards a specific function, and the non-key are the muscles that are in the area that also help. So it's important for us to have a comprehensive exam about your strength. We're going to check your sensation to a few different modalities, and they're all very important. So we're going to check your ability to sense a light touch, so something like a cotton ball or a cotton swab, pinprick, which is more for a painful type of stimulus, and proprioception. And what that means is your ability to sense when a joint is moving and which direction that we may be moving it in. We commonly check this in the toe, the ankle, the fingers, and the wrists. Why are all these important? Because all of these sensory modalities are going to help you experience your environment, understand your environment, and can have negative impacts on your balance and your mobility. We're going to check your cognition. Why? It's going to be important if we're making any decisions about therapy and carryover for information that you're receiving, and also if we're making any decisions on adaptive equipment, because we want to be able to make sure that you can use it and use it effectively. Your blood pressure and fluid status is going to be important. Important because when we're upright, we have to be able to maintain our blood pressure so that we don't become dizzy. So we're trying to prevent any kind of negative impacts of your activities. What is your skin integrity? Do you have any history of pressure-related injuries? Do you have any injuries to your skin because of impaired sensation? We want to check not only on your sacral area, we check your, what you call your ischium, kind of your bottom where you were sitting, we check your legs. We want to know, we want to make sure that anything that we are using, we don't impair your skin or cause any further injuries. We're going to check for those skeletal anatomic abnormalities and make sure we put those into our decision making. And if you're able to, we're going to get you up, we're going to walk you. We want to watch what your mechanics look like, both during your transfer and during your actual walking. All of this information really helps us understand what kind of impairments that you have. So a neurological level of injury is if we're talking about the spinal cord, at what point is your spinal cord injured or impaired? Is there a specific pattern that will be helpful for us in terms of any rehab efforts we want to implement? Do you have pain? We want to make sure that we're addressing this. What kind of musculoskeletal contributions do you have that are going to have an impact on your mobility? And how can we address these things? What kind of precautions? Do you have any precautions in terms of how you're able to move your spine? Are you able to move it in all planes? The same thing for your arms and your legs. And we also want to know if you have restrictions to how much weight you can bear on your arms, your legs, or even, your sacral area. What are your anticipated treatment and clinical outcomes? I know, we're gearing a lot towards survivorship, but, are you in active treatment? Is there a recurrence? Is there something that we need to take into account? Because we want to make sure that we're giving you the best quality of life at all different time points, and we're addressing your needs at all different time points. And ultimately, what are your goals? And that's probably one of the most important things. We want to know what it is that you need to do and what it is that you want to be doing. And we want to make sure that we're addressing that and we're not forgetting it. When we move on from just our evaluation to establishing a rehab plan, the whole team is still there in terms of your primary treating team, but maybe the focus is a little bit shift. Again, you're always going to be at the center with your caregivers and your loved ones, and those are in the community who are supporting you. But now surrounding you will be your physiatrist, your physical and occupational therapists. If you have any vision impairments, the ophthalmologist, the certified prosthetist, orthotist, if you need any bracing, and our equipment specialist, if that's what you also need. So always remembering, and these are some of the key players that you could be asking for, or you could be seeking out in your community based on what your needs are. If you have pain, we want to make sure that we're addressing it. We want to know the severity of your pain at baseline. So in other words, when you're not doing anything, and with different types of activities. This helps us to determine what type of medicine may be most appropriate to help your pain, whether it be something orally, something that's injected, something that you could use topically. And we want to know about the timing of giving it to you. So making sure that we're addressing your pain when it's occurring. In terms of therapy, I think every time someone thinks about rehab, this is what they're thinking about. So what do our therapists do and what roles can they play? You may be referred to a physical therapist to help you improve your muscle strength, to help you improve endurance. So the ability to tolerate the different activities that you're doing. We focus on standing and balance training, working on any sensory impairments you have, and really trying to retrain your brain to what it's feeling and help you understand different sensations that you are feeling when you're exploring or navigating around your environment, ones that are positive and ones that are negative. Helping you with any kind of transfers. And these are, again, from bed, getting in and out of bed, getting on and off the toilet, getting in and out of a chair, in and out of a car, all the transfers that you would need to do for your day. If it's appropriate, we'll institute gait training. So what that is your ability to walk and make sure that we're addressing all different types of surfaces for you. Wheelchair mobility, if that is something that you may need. We're going to address pain. There are modalities that therapists can do to help you with that. Stretching is going to be important, really focusing on your flexibility, your range of motion. We're going to give you an exercise program to help at home. And oftentimes they may also help with any kind of equipment you may need. Occupational therapists do some of the same things, but they're going to focus more on your fine motor skills, your upper extremities and your hands, positioning on different surfaces. And if you have a wheelchair, your activities of daily living, all the things that you want to and need to be doing. They can also help in terms of pain, giving you a program to do at home and helping you with some equipment. And the equipment that they're going to help you with is more about things negotiating your environment as opposed to just those such as a cane or a walker, or even giving us some recommendations on bracing that you may need. Vision therapy. So this is something that may or may not have been brought up to you. And I think that everyone has a little bit of a different approach. Sometimes, they're addressed with different types of glasses or eye patches or prisms. But I think it's really important that if you are having any type of vision impairments, you want a thorough, comprehensive vision evaluation to really understand what these impairments are and how they're impacting your negotiating of an environment and how they're impacting your mobility. There are some optometrists who are actually trained in doing physical therapy for the eyes, so giving you different exercises to help improve visual perception, visual processing. And sometimes if you have any kind of balance impairments, these types of vision therapies can accompany therapy that's just geared towards balance or vestibular type of rehabilitation. When we talk about equipment, we're talking about bracing, any kind of assistive devices that you may need, your wheelchairs, and what we call other durable medical equipment. So this would also fall in terms of your assistive devices. When we talk about bracing, we think about our spine. So if you have any kind of spine changes in your posture or your alignment, we may do it to focus on that to help with pain, to help with any instability, although more often than not, if there is any instability, that would be a conversation with our surgeons. And we may also incorporate bracing onto your extremities to help you with any kind of weakness, overcoming it, compensating for movements, helping with any kind of joint contractures, whether it be to stabilize them or to gain more range of motion for you, and help again with any kind of musculoskeletal abnormalities you may have in an extremity. Just to show you some of the spine braces, some of them are a little bit older, some are newer types of things that we're using. But anytime you hear about a spine brace, it's going to be named based on the region of the spine it crosses. So if we're thinking about just our neck, it's going to be a cervical orthosis. If anything that's incorporating our chest and our lower back, it might be called a thoracolumbar orthosis or TLO. And if we're incorporating the sacrum, we're also going to incorporate a TLSO. So that's where the sacrum gets involved. If it's just the lower part of our back, it may be an LSO. When we talk about extremities, similar to the spine, anything that we do is going to cross multiple joints, and we're going to name them based on that. This is going to be an ankle foot orthosis or an AFO. This is going to help you if you have any weakness in terms of moving your ankle up and down. If we add the knee, it'll be a KAFO. And if we add the hip, an HKAFO. The more that we brace on your leg or the higher the brace goes, it does take more energy to actually operate it. So we try to be very mindful of how much strength you do have in your leg and where you're going to be walking. So whether it be in your home or outside in the community, to really make sure that we're getting you the right thing and something that you can tolerate. Based on your needs and your upper extremity function, in addition to therapies or bracing, we may recommend an assistive device such as a cane, a walker, crutches, really taking into account what your balance is, what your functions are, what you need to do, and what's easiest for you to actually use. Wheelchairs may be part of your mobility plan. If we do this, we do work with those certified technology specialists or adaptive equipment specialists. An in-depth evaluation, again, is going to be key. Any wheelchair you have shouldn't just be something we pulled out from the closet. We really should be thinking about what it is that you need, customizing it in any way that we can to you. We want to make sure that it fits appropriately. There's not pressure in any area that can cause any kind of skin impairments. What is going to be most appropriate, whether it's a manual chair that you operate on your own or a power chair, where there is components where you're actually driving the chair because there is a motor. And we think about different things such as what kind of cushions you may need. Do you need any safety? How are you going to drive your chair? These are just two examples. You see with the red, that's going to be a manual wheelchair. We always try to make sure that's as light as possible. And the larger of the two wheelchairs, that's going to be your more power wheelchair. Finally, when we talk about your mobility, we're thinking about other durable medical equipment that you may need, whether it be a lift to help you with transfers, sliding board transfers of different types, whether it be a tub transfer bench to get you in and out of your chair, a stander if you're not someone who's going to be otherwise walking, but we want to make sure that you can be upright, interact with your environment, reach things. So all of these things are we taking into account. And so I just want to round it back and remind you that you're always at the center of this. All the different key players in your care, all the different kind of providers that you can reach out to. And just end it with some resources that may be of help. The Paralyzed Veterans Association does a great job with consumer guidelines. And the American Spinal Injury Association does have some good resources available as well. In addition, there's some good spinal cord communities. A lot of these are geared towards trauma, but there are a lot more patients who have spinal cord disease or spinal cord injuries that were not traumatic related who are now part of these support groups. So I encourage you to reach out and just some resources in terms of finding a physical therapist. And with that, I will say thank you and stop sharing.
Thank you so much, Dr. Ruppert. That was a lot of really great information. I'm sure there will be good questions for you at the end too. We already have a couple. So I just want to remind everybody that you can go ahead and submit your questions now, which will be helpful for me to organize them for the end. If you were not here right at the beginning, you can click the Q&A button and the window will pop up where you can submit those. So thank you very much, Dr. Ruppert. And so now we will turn it over to Dr. Brown, who will talk about the role of reconstructive neurosurgery.
All right, can you see all that?
Yes, we can.
Okay, perfect. So I'm Dr. Brown, and that was a great overview. I'm going to get into a little bit of what can we do about these deficits that were left with surgery, left after resecting these lesions or having addressed chordoma surgically. So there are ways to fix a lot of the deficits that are encountered, and sometimes people aren't aware of them. Sometimes in the same medical centers where folks who take care of these problems work, people aren't aware of them. A lot of these procedures were developed for bad nerve injuries, for people who fall from motorcycles and rip the nerves in their neck, or other types of problems. And sometimes they don't look outside of those indications to apply these things. So as you all know, chordoma can be at the clivus, it can be down here at the sacrum, and really it can be anywhere in between. It can be in the cervical spine, it can even be in the thoracic spine. And each time we go in to take care of these things, my colleagues have gotten very, very good at this. When we get it, we have to take the whole tumor out, and often to take the whole tumor out, nerves have to go with it. So here's a tied off nerve root, and the tumors come out from the front. This happens down to the sacrum as well, sacral nerve roots, lumbar, well, that's another sacral nerve root. They have to be transected, and then we can get the entire lesion out. And there are very creative ways to remove these, and we're very excited about a cure. But when we're done with these, we're often left with deficits that many folks aren't aware can be fixed. Another situation where the tumors grow large and actually will compress the spinal cord, and people will get toned, they'll get spastic. And that requires a lot of rehabilitation. But again, there are procedures that can help with that spasticity, improve movement. So what are these procedures? I would say the most common one that I do is called a nerve transfer. And let me show you what that looks like. So in a nerve transfer, if we have an arm, let's talk about cervical chordomas now. That picture I showed earlier where we took a couple of nerve roots out. If we have hands that open and close and elbows that flex and shoulders that work, if we have to take out the upper two nerve roots to resect a tumor and we're left with a working hand, we can find a way to rewire that. So we're missing a biceps, the arm is hanging at its side, we have a median nerve that makes the hand close here, and we go take a nerve to the biceps, and we can splice into this wire here of the median nerve. And once those are tied together, they will grow, and they head on down the pathway, and they'll re-enter the muscle. And initially, someone will have to close their hand to get that biceps muscle to work, as you'll see here. And then with time, you sort of figure it out and you end up kind of back where you started. You get a pretty good biceps, and you got a hand, and they work independently from one another. So there are a number of procedures like this. That just happens to be one of the most famous ones we can do. Now, this gentleman had similar injury. It wasn't a chordoma, but he lost C4, C5, C6, and C7. So he had some triceps left and hand left, and we had to go put him back together. So we did these nerve transfers, and this is kind of an average outcome. Some folks get these wonderful arms look completely normal, and some folks get some function.
Try to bring the arms out to the side.
But let me mute him. So this is when he first noticed that his arm started working again.
Right, now going up from the side, go ahead.
And he's squeezing his hand for the biceps to come up. And with a little more retraining, it gets it all figured out. And now he's got a normal working arm, which previously hung at his side with no shoulder at all. His shoulder comes up, and it comes up to the front. And so these procedures work well. And of course, I have to give you one of my really great outcomes. Here's a guy who had the same procedure done and unable to put a stool in his hand in the clinic, and he can curl that. So there's a whole spectrum of results, but the point is that we can rewire when nerve roots are missing from something else and usually get the body to work once again, but often folks aren't aware of this. And depending on how severe the injury is, we get a little bit more aggressive with our procedures. We can go to the other arm, and we can move a nerve root across from the good arm to the arm that has paralysis and build a bridge there and get that going. And this young man lost every nerve here except T1 to run his hand. And we had to do a bunch of little nerve connections with him. So the remaining nerves We were able to get his shoulder back into the socket and some basic control there. But then we got him to be able to flex his elbow and externally rotate his shoulder. And compared to where he began, where his shoulder was just sagging down to the side with no control at all, he's doing quite well. Now, some folks, all these procedures I showed so far, you sort of have to get to us in a reasonable amount of time, within the year, and ideally within 6 months of the time those nerve roots were lost. Sometimes folks come when it's a little bit too late and we have to come up with different strategies, but we often can. And so this lady lost the nerves again that flex her elbow and move her shoulder, but she had good muscles that pull down. So the latissimus, which allows you to pull your arms down to your side, was still available and quite strong. I apologize, I've got some graphic images coming up here. We're able to take that muscle, move it into the arm, and create a new biceps on both sides for this young lady. And so with that, she has essentially a very normal ability to flex her arms. And so we have yet another strategy to restore function in somebody who's lost it. And she's got her purse just full of stuff, a very heavy purse, and she can transfer that between arms. And again, she's regained essentially normal function. So this can be done for any number of deficits. Triceps are lost. We always take from something that has two muscles that run it. So this is the shoulder complex, and to rotate your arm out and away from your chest. It's called external rotation, and there's two muscles that do that. This is called the infraspinatus, and this one's called the teres minor. So if you got a great infraspinatus, we say we can steal this one and you won't miss it, and I can run its nerve into the triceps. And that's what we did for this young lady. We didn't do it on this arm, so I'm trying to demonstrate the difference. So she can't get that one over her head, and the one that we did this transfer on is this side here. And it took about 12 months for that to grow in and work, but now she has wonderful ability to bring her arm directly up over her head. We can do this down to the forearm and hand as well. Here's a patient who had a paralyzed hand and losing the nerve root. So her wrist comes up and it looks like she's closing her fingers, but she has just very, very little function. After we put some nerves together, suddenly she has the ability to open the fingers wide, close the fingers, and then we do a little more finger positioning, and suddenly they can really do everything with a hand that had absolutely no finger function whatsoever before. There is, like the last talk mentioned, there is a lot of therapy involved in this. You have to learn how to use fingers using a different source than before. There's a lot of retraining. It's like learning to play the piano or something. But all of these are possible. And the other deficit we get into is, as mentioned before, is these tumors grow and they compress the spinal cord. They can often get these out entirely, but that cord may have taken a hit. You may have a lot of spasticity. The spasticity is difficult to deal with in some patients. Big muscles like the triceps, Botox is a nice way to relax muscles, but sometimes these big muscles, Botox just doesn't work very well. And this gentleman who had spasticity couldn't reach his mouth. The muscle would turn on and resist his ability to try to flex at the elbow. And so we go in and trim back some of the nerves to his triceps. And the next week he comes back in the clinic.
2 weeks later? Yes. We're 2 weeks after surgery.
2 weeks after surgery. So he comes right back to clinic. We ask him to do the same task and he can get right up to his mouth and it's no problem. And it's an enduring effect. Once you take care of that, he's going to stay like that for the rest of his life, and he still has control of the triceps. Feet that get spastic when that spinal cord is injured, everything below it will get increased tone. A lot of times we get feet that kind of turn in and the toes curl, and it becomes difficult to walk, and people have to wear the AFO brace to hold their legs straight. And we can do the similar procedure, so our graphic images again, where as the nerve branches into the muscle, we can take a subset of those branches and reduce that spastic tone. And then we can get them walking much more normally. And a lot of folks actually can take the brace off and get rid of it after a procedure like this. And if that doesn't do the trick, we can get our orthopedic surgeons involved and split a tendon and balance the foot off. This is a young lady who we went through the nerve procedure followed by the tendon procedure, and she was really motivated to get out of her brace. And we finally did get her out of her brace. And she came with a foot that was really dramatically turned in and down with toes and a fist. And now she's graduated to be able to walk quite well afterwards. So there really are a lot of procedures available. And the next one that we're working on, we've just done patient number 1. is what do we do when we've had to cut all of the sacral nerve roots and we leave folks without the ability to control their bowel and bladder? So the procedure we've been working on in animal models for about a decade is, can we use motor nerves to restore function to the bladder? And we have done this very successfully in animal models for some time. They're tiny little nerves here. We transfer our motor nerve into this nerve, and this is the bladder. On the side of the bladder, it will grow its axons in and recover that bladder. And here's the demonstrated function. It's a bladder that's full of fluid. And as we stimulate it, bladders very slowly contract to expel urine. And you can see our little graph here showing the pressure curve rising as we stimulated the transfer nerve. So our first patient had this done just a few months ago, and things look like they're going well. And so I don't want to tell you it's a home run yet until he is using it appropriately. But the point of all of this is that there are a lot of procedures available. It's better if we do them early, but even if you come late, there's a lot we can do to restore function to folks who've lost function for these curative resections that really can be quite morbid. They can cause a lot of weakness and paralysis. In order to cure you, there are things we can do to bring that function back. So thanks so much for your attention and your time.
Thank you so much, Dr. Brown. That was the videos and animations and things were really fascinating to see. And so glad you had those videos to show us. I know that surgery videos can be difficult for some people to watch sometimes, but that was really helpful in showing what kind of procedures you do and how they work. So that was great. Thank you. So we will move into the Q&A now. So if you can both turn on your videos and we can all be on camera at the same time. Okay, so we do have a number of questions. So we'll start with this one. If you traveled for treatment, any suggestions on finding a qualified team at home? So to go along with this is sometimes people feel that they almost have to build their own teams if they can't find someone like a physiatrist close to them, that but maybe there's physical therapy or occupational therapy. Mm-hmm. So building your own team and just how you find those people. So Dr. Ruppert, I'll turn that over to you.
Sure. So I can definitely understand the struggle. And, you know, I think some of the best ways to actually look at it is based on what your impairments are when it comes to a physiatrist. You can, if you're having a lot in terms of brain or in vision, so more of the balance that may not be coming from the spinal cord, you can see someone who is a general physiatrist, or you can look for someone who actually specializes in brain injury. Their background may be in traumatic brain injury, but there's a lot that they do that they can adapt for you. Similar, my background is actually in traumatic spinal cord injury. There is no cancer-related spinal cord injury training, so a lot of what I do, I've learned along the way. But I take the knowledge that I have from spinal cord medicine and I use it to apply. And I try to base the approaches that I would take in terms of recommendations based on what your impairments would be. So I would encourage you, if you know that you had spine or spinal cord involvement, to seek out someone who has spinal cord training, similar for brain. If you have musculoskeletal abnormalities, I think any general physiatrist would also be able to help you. There are also a small subset who specialize in cancer rehabilitation medicine. And so those might be providers that can help you as well, because they will have some experience with this. So the one recommendation I always tell people is look for your major academic medical center near home. See if they have a rehab department and see what kind of physiatrists they have. If you start with a general, I promise they will point you in the right direction. If you can find someone more specific, I think that's a great way to go. Same thing in terms of your therapies. If you look up any rehab department or any, physical or occupational therapy department, they'll list all the different diagnoses that they treat. And so sometimes that's a really good place to start. So if they say they do a lot of gait training or they can help with balance, that's a good way to approach it. One of the resources that I actually put on was the APTA, the American Physical Therapy Association. There's actually a link on their website that says for patients, and it gives you a series of questions to fill out: where you live, what you're looking for, what type of therapist, what diagnosis you have, and it will tell you within however many miles you pick what physical therapist can do this. The Occupational Therapy Association has something similar. So I would encourage you to use that. I think Shannon, the Chordoma Foundation has, I know, been great in terms of pointing out different providers, but you can also reach out to some of the spinal cord support groups because they'll know who's in different areas or which different providers there are. So you don't need someone who, specifically can, treat chordoma, because you may not find that in terms of physiatrist, but I would say find one based on the symptoms that you have.
Thank you.
And yes, I can post the APTA website.
Okay, great. So, and I also wanted to mention, if people joined a little bit late and missed it, we are going to post PDFs of the presenter slides on our website. So those will be available to you. There are some great resources listed in Dr. Ruppert's last slide, so you'll be able to find that. So similarly, Dr. Brown, obviously what you're doing is super specialized. And so we know you're at the Paralysis Center at Mass General, which you are the founder of. Are there other centers that are similar to that Paralysis Center in other parts of the US that are doing the same type of treatment and work that you do?
There are. I'd say it's similar to chordoma surgery. There's probably a handful. And a lot of the centers are sort of divided by location. So one center for the leg, another center for the arm, another center for the face, depending on what it is. So I could list off a few, or maybe I could email you kind of based on what they're looking for. But yes, there are probably a dozen centers that do these sorts of treatments.
Yes, so we're going to write a follow-up blog highlighting some of the points from this webinar. So if you wouldn't mind, if you could email me the names of those centers and what their specialty is, then we can include that list in the blog post as, just a reference point for people. So that'd be great and good to know. Okay, let's go back up to the top. Can you, Dr. Ruppert, can you please explain what vestibular therapy or rehabilitation is?
Absolutely. So vestibular rehab, everyone always thinks of vertigo. It's typically the type of therapy that you would go to if you had vertigo or the idea of the room is spinning. But vestibular therapy is more than that. It's actually geared towards your ability to know where you are in space. So if you were standing or doing different movements, to know that your head was definitely above your feet, where your arms and your legs are in your environment. And as you're moving, if you get any types of loss of balance or any dizziness that's occurring during those movements, they teach you to help compensate for that, or actually teach you strategies to help alleviate that so it doesn't happen at all.
Great. So we have two similar questions, so I'm going to kind of try to combine them into one, but they're both from sacral patients, and they're wondering how they would know if they might be candidates for the types of surgery that you're doing, Dr. Brown. And I think that could probably apply to any chordoma patient, is if they know they have nerves cut, they know they have nerve damage, how would they know that they should kind of consider consulting a reconstructive neurosurgeon?
Sure, it's the stuff that's obvious. There's nothing subtle about this. So if the foot doesn't lift up, if you have no control of your bowel or bladder, if you can't extend your knee, if there's a major paralysis, then it's worth looking into.
You mentioned if you wait too long, is there a time frame? If someone was treated 10 years ago or 2 years ago, is there kind of a time when it's too far away from the surgery?
Yeah, so when the nerve roots are resected, when it's a kind of a floppy or flaccid paralysis, it needs to be treated within the year to have the most options available. But as I mentioned, when I removed the muscle in that one young lady, there are other options available later. They're just bigger operations, and there aren't as many of them available. So if you can get to a surgeon within 6 months, that's ideal, still within a year. But beyond that, there's still something we can do, but it'll be less options.
Okay. And I think from what I understand, the sacral nerve repair is is something you're just starting to work on and not really ready for prime time and doing this on a lot of patients yet?
If we're talking about bowel and bladder, we've got a very select group we're enrolling for that right now until we demonstrate that it's effective. If we're talking about the ankle and foot, that's normal clinical care. So I'm happy to take care of anybody whose ankle and foot doesn't work.
Ankle and foot and hands and arms would go in there as well. And yeah, okay, very good, thank you. So Dr. Ruppert, this is a question that we get a lot for specialists and doctors who deal with side effects from chordoma. Chordoma patients know that, or come to learn that they should seek out treatment from doctors who have experience with chordoma when we're talking about their initial surgeries and radiation, any systemic therapies they might need down the line, and that chordoma experience is very important in getting the best care. Can you talk a little bit about whether or not the specialties that would deal with side effects need to have that kind of experience with chordoma specifically?
Sure. Ideally, it'd be wonderful. It's definitely a different type of challenge. I think that's kind of where it brings back to the idea of the multidisciplinary team and who all the different key players are. So you may find a physiatrist in the community near you, or a therapist in the community, a CPO, or someone who does equipment in the community who has treated patients who have brain injuries, musculoskeletal injuries, spinal cord injuries, and they have that knowledge, but they may have never seen a chordoma. And that could be a challenge in a way, because there's certain aspects of your care that make you different than those other groups in general. But if there's good communication with that provider and your actual chordoma treating team, we could bridge that gap. And your treating team can actually provide answers to the questions that these professionals may have who are treating you now, or if something does come up and they're unsure of, they may be able to provide guidance. So I think it's okay that your team expands out beyond those who just know about chordoma, and could be just really good specialists in their areas. But you have to make sure that you're at the center of your care and that your treating team is part of any decisions that we're making, just to make sure that we're taking anything into account, or if there's something we don't know, that we find out the answer to make sure that what we do doesn't hurt and that it benefits.
Got it. So if patients have just started getting treatment from a physiatrist or someone else that is not in the same center as their treatment team, that you're saying they should make sure that not just that they get all their medical records and that physiatrist can read over it, but that there's actually a conversation that takes place between the physiatrist and, let's say, the surgeon, to really understand what's going on there.
Absolutely. I think that's the most ideal situation. And I don't think you'll ever find a physiatrist who'll say, no, I will not call. And I think, even, taking the idea of the things that Dr. Brown does, I don't think he would want me taking care of his patients without being willing to have a conversation about any kind of surgical procedures that he's done, especially if it was something I didn't have knowledge of. So we always want to make sure that we're open to the conversation. And I can tell you that all providers will be open to that conversation.
Great. Dr. Ruppert, you also mentioned it was specific in your presentation, it was specific to a neuro-ophthalmologist, and you mentioned making sure you get a very thorough evaluation from them. How would a patient know if they are getting a thorough evaluation? I think not just for neuro-ophthalmology, but really when talking to any new provider about their mobility issues, is there a way that they can tell that they've really gotten that thorough evaluation?
Sure. I think this might be the setting where there might be some optometrists, particularly those who have any kind of neuro training, that may be able to help you. But this might be the time where you really want to make sure you're seeing an ophthalmologist, because they do a little bit more than the vision check you get when you go into Lens Crafters or whatever local eyeglass place that you may have. So you want to make sure that they're definitely doing a little bit more of that. Ask about their experience. Have they taken care of patients who have any kind of neurological impairments? Bring up your symptoms about any kind of vision impairments you're having and how they're impacting your mobility, so that they know to take that into account and that you're not just here because you want screening for glasses. So I think it kind of goes back to, if you can do it in your major academic center in your home, you're probably going to be fine. But I think you can also just check to see what someone's experience is and ask them. And if they don't personally have experience, I'm sure that they can point you in a good direction. SUNY Optometry here is great in New York. And it's one of the places that we frequently use. They are optometrists, but they do have a specific brain injury program and low vision program. And that's one of the reasons that they're great, but they also know providers who are in the community. And I've had patients who've been from other states and they've been great about pointing me in a direction of someone who can actually help.
That's a good point to make, is that you're with the specialist that you might see right after your treatment, your actual chordoma treatment, that being, you know, really asking, can you connect me with people? I live here, and you know, who's the closest to me? And also, just to be clear, when you say academic medical center, that's really, you know, it's a hospital attached to a university. So they're teaching medicine and also practicing medicine, and those are usually the bigger centers. Just in case that was a question from anybody.
Exactly. And I think, you know, some community hospitals can, you just may not find as many resources as if you look at more of a bigger hospital system.
Yes, good point. So Dr. Brown, there's a question about neck movement. If C1 to C4 have been removed, so those cervical patients that might lose function in their neck, is there a way that your reconstruction procedures can help with that?
Not very well, unfortunately. When they resect those, they fuse all of those bones together and they become one neck bone. It would be very dangerous to try to free that up and restore more movement. So unfortunately, right now we don't have anything for that.
Okay. So the movement would mostly be impaired because of the hardware that's there that is keeping the neck from moving.
That's there, right? So they should still have the ability to rotate side to side, but there's going to be some restriction in going down and going up, and that's usually permanent.
Dr. Ruppert, do you ever work with cervical patients to just try to optimize the strength that they have, that they may not be able to tell what's permanent and what is just my limits, and also just strength I might have lost along the way?
Absolutely. And I think that goes back to the idea of the conversation with your treating team. What kind of surgery do you have? What kind of hardware do you have in place? Where is your hardware? And in terms of looking at, you know, your spine anatomy and just knowing where your spine would move, what can we expect? What will you still have? What won't you have? And then looking a lot about your overall posture and movements, and trying to actually help you compensate for any deficits that you may have. Teach you to move within your allowable range now and strengthen any muscles that are still in that area. And that kind of came with the being really comprehensive about looking at all your muscles and all your sensation to see what muscles in the area may be helpful, so that we can teach you different types of movements or different ways to hold you up and strengthen, or use other muscles that have a similar function to do the things that you're hoping to do or compensate for it.
So with that, you know, there's a lot of this care surrounding patients right after treatment when they're still in the hospital, or maybe they spend some time in an inpatient rehab facility before they transfer to outpatient. But if a patient feels that they have been discharged from PT or OT or whatever therapy they're getting a little too early, and they still feel that they have needs, what advice do you have there?
I think everyone feels that way. You know, unfortunately, there's a lot in terms of insurance that comes into the decision for plans of care and length. And it's something that we're always fighting for. But it's really common to feel like, oh, but I still have goals to make. Oh, there's still things I could have worked on. Oh, you know, what about these type of things? And I think that's where making sure that you are plugged in with a physiatrist or a good team that's coordinating your therapy care can help. Because it may be that right now it's a break from therapy, but there's other things that we can do, exercise programs that we can make sure that you have to maximize what you've learned right now and get you prepared. So what I always tell patients is that just because you were discharged from therapy today doesn't mean therapy is gone forever. Look at it as a pause. You and I continue to follow up with each other. We continue to talk about the things that are happening. And then, you know, based on how you're doing, whether it's you progressed, you got stuck and there's things that are challenging you, or if something else happened and there's new things we need to work on, then we revisit therapy. So it's never fully ending just because it ended today, is what I always say to people, and that we're always going to continue to work together and check in together to make sure that all needs are met. The other thing to remember is that something new may have come up. So you might have been in a therapy course, but say you sprained your ankle in the middle of it and it had nothing to do with anything. That new diagnosis helps us actually justify something new. So if something new did come up and that's what kind of didn't let you make the progress you were hoping for, then obviously we have to take that into account. But like I say, don't look at it, it's over forever. It's over for right now. Let's make sure you have something good in place. And then let's keep working together and plug you back in when we need to. I also say be a good advocate for things. And I try to help my patients in terms of those who are finished with therapy, what else is available, you know, in terms of exercise programs. Emory and the Shepherd Center were great working with YMCAs. I know all over the East Coast, I'm not sure how far they got, but basically working with personal trainers who were in the YMCA understand spinal cord injuries because they had patients who were leaving. They felt like they were leaving early. They needed more than just what the therapy could get them. And so they wanted their patients to feel confident going someplace and knowing that their needs would be met. So I think exploring options like that is great too. You know, reach out to any rehab center or the rehab center you went to. Where do their patients go when they're done with therapy? Do they have any recommendations? One of the resources I had listed was the Access Project, which is a gym in New York that was based, it was a physical therapist who specialized in spinal cord injuries who got frustrated because he always felt his patients were discharged too soon. And so they actually now have an entire program where people can come and exercise there, and they do other types of activities. But there are places like this all throughout the US. And that's where kind of looking at the different spinal cord communities is helpful because they can actually tell you where these places are.
Okay. So we're at our hour, and I know Dr. Brown, you're going to have to run. If you have time to address facial nerves, cranial nerves, you know, things that would cause pain in the face. And Dr. Ruppert, I think that's for you too. Any information there? There's a few different questions about that we haven't talked about yet.
Yeah, let me give a quick rundown of that. Yeah, facial nerve works the same way. There are lots of strategies to restore paralyzed face. Same situation, you want to get to it within a year, but if you're well beyond that year, we can move a muscle from the leg into the face and achieve it that way. Pain, I have plenty of colleagues who do surgical management of pain, but I'm sure Dr. Ruppert can also tell you about her colleagues who do non-surgical methods for that. And that also needs to be approached as a team because these sometimes can be very ambiguous pain sources. And it's sometimes hard to drill down on exactly what's causing the pain. And what was the last part of your question?
I think that was just it, is what can you do with facial cranial nerves? I know you and I've talked before that eye movement and things like that, you guys really aren't there quite yet with those nerves.
Does have some ways to correct the eye position. It's not 100%, but there are a lot of options there. Of the cranial nerves, the facial nerve and the shrugging or spinal accessory nerve are the ones that people like me can reconstruct. The ocular ones, again, ophthalmology and hypoglosssia wouldn't repair, and the fifth cranial nerve, which cues and gives facial sensation, also you typically would not repair that.
Okay, thank you. Well, it sounds like you have to run, Dr. Brown. Thank you very much for your time. Dr. Ruppert, if you're able to stay, there's definitely a couple more questions for you. We'll stay on for another 5 minutes or so. Thanks, Dr. Brown.
Bye-bye.
It's sort of a similar question, that the main thing with the nerve damage is pain. And we hear this a lot, that pain isn't, and we have, for the person that asked this, we also have a pain management webinar that you can check out on our website where we go into this a little bit, but if the pain is what's keeping you from moving around because it hurts to move, you know, that is a mobility issue. So if, you know, we hear a lot that even the strongest medications don't really help with this type of pain. And so that's where physiatry and rehabilitation can come in. So could you talk about that just a little bit?
Sure. So I think pain is a very interesting thing. And, you know, we talk about pain that is true pain, and then there's pain that's sensory. And I think that could be a challenge too. So it's really working with you to understand what it is the pain, what is the pain, what are you actually experiencing. I have a few patients who have tried everything, and you know, nothing really ever touched their pain, and mobility was a big issue. And when you really sat down and started to get a handle on what was happening, it was actually they were bothered by the fact that their sensation was off. And it was more so this pain that I can't really feel, you know, my leg, and it's so painful because I can't feel it and I can't move it. And we actually took a different approach altogether. And then it was about sensory integration and helping you to understand where your leg is and what you're actually feeling. So when we have an injury along the length of a nerve or to the spinal cord, we disrupt the flow. And I think we understand the motor piece. You know, the brain sends a signal down the cord, it doesn't happen, so something doesn't move. But at the same time, that same signal goes from your foot up to your brain, telling your brain where it is your foot is, what it's standing on. It's hot, it's cold, it's sharp, it's not. And so if that signal doesn't go up and down, that's actually a really painful experience as well. So it's really trying to understand the pain. And if it is more of a sensory thing, addressing the sensory piece of it. And yes, you can do that with medicine, but there's a lot that we do with different types of touch, reintegrating touch, exploring touch in an area where it's not normal to an area where it is. There's a lot of different textured surfaces that we could use that help with that as well too. And sometimes just the manual work helps. I'm also a huge believer of water-based exercises. The pool gives us sensory feedback to our arms and legs in ways that we can't get on land. And so sometimes that actually helps too. Yes, totally different than when it is with the face. The face is a little bit more of a challenge, but sometimes the tactile work, sensory feedback work to the face does help. This is a place that I work very closely with our anesthesia pain colleagues, where they may do the injections for different types of pains. They're actually also exploring things like ketamine to help with sensory types of pain, but we work very closely to understand where pain is coming from, why you're having this pain, and then we try to actually address it from that standpoint, if that answers the question.
Yes, and thanks for kind of bringing the face back into it, because there is a question specifically about physical therapy and the face, and if there is physical therapy specifically with facial issues, and it sounds like the answer is yes.
Yes. So two ways to actually approach it. If you get, and this might be a place where you get a therapist who understands cancer, similar to a lot of the head and neck cancers and the types of patient they're treating in terms of any scarring that's in the area or any nerve injuries, they'll actually both work on sensory feedback to the face, muscles that are moving the face. They'll also go into the mouth as long as your jaw can tolerate it, and do some internal work to try to help with that as well too. So there is a good amount that we can do therapy-wise for the face. We also do a lot in terms of trying to correct symmetry in the face with different types of exercises. If a physical therapist isn't available in your area or doesn't know, speech therapists do a lot of intraoral work and a lot of work with facial muscles just as they pertain to speech. So that might be a good way. The other thing you can do is explore a lymphedema therapist in your area, where even though you don't have lymphedema or swelling in the face or neck, sometimes the massages that they're actually trained to do can be of benefit for it.
Oh, good. I didn't know about that. That's good to know. And so speech language pathologist would be a type of physical therapist, and they also can help with swallowing and things sometimes,
yes.
right?
So they're actually, so they're speech therapists or speech and language pathologists. They're a completely different field within medicine, but they purely focus on speech formation and swallowing and all the nerves and muscles that go into both of those tasks. So they're actually really good to have on board if you have any kind of facial impairments or any kind of swallowing difficulties.
Okay, great. There's a question about medications for shakiness and tremors. Are there medications for that? And also with the things that you just mentioned about dealing with pain and numbness, are the treatments for tremors similar to that?
So yes, in a way and no in a way. So again, we always want to figure out where things are actually coming from. A lot of times for any kind of tremors or any kind of sensory impairments, we use a class of medicines called nerve stabilizing medicines. A lot of these were designed initially for seizure management, but we realized that they actually helped more with nerve pain than managed seizures. So there are medicines that are oral medicines that can be used for both sensory impairments to try to help with the discomfort you experience and with tremors. With tremors, I really try to focus on where is the tremor coming from. Is it more sensory mediated? Is it related or unrelated to your chordoma and its treatment? And we try to incorporate a lot in terms of therapy using things that are weighted to try to help you control the tremor as well. I tend to try to do a lot more conservatively first in terms of using therapies or using kind of adaptive equipment or modifications to what you are using first. Only because a lot of these medicines can be somewhat sedating. So we always want to make sure if you're already having mobility impairments that we don't make you groggy in any way, causing a fall. So it's always a fine balance. And we also acknowledge a lot of times there's a lot of medicines that you are on. So we try to do as much as we can without adding to it unless we really need to.
Okay, great. We do have just a couple more. Specific to, so we've talked some about nerves being cut or damaged during surgery, but radiation can also cause that kind of damage. And for some patients, it happens right away, and some patients, it's more of a late effect. So years after radiation, things kind of just start to go wrong, I think is the way to put it. So if we're talking about radiation for skull-based patients, and there can be hearing loss, vestibular loss, tinnitus, all of those things that are caused by the radiation, and that especially the vestibular loss can really affect balance and cause those balance issues. What type of specialists would be consulted for that?
Sure. So you're right. You know, a lot of times, especially if it's surgery, we can understand that nerves are cut and the impairments happen right away. But radiation sometimes has a way of sneaking up on you, unfortunately, and it can be years out where you start to develop deficits. And the hard part is it's that the radiation can impact not only the target, but things that are in the surrounding area. So you might have some impairments that weren't quite particularly related to the area you were treated, but nerves that were in that surrounding area. So the idea of now we're impacting in terms of the ear. Tinnitus can be tricky to actually treat. There's not such great, you know, we try with different medicines, so it's not always a perfect thing. There are ENT doctors, ear, nose, and throat doctors who specialize in tinnitus. So even though they may not have chordoma experience or have treated patients with radiation, a lot of the things that they do for vestibular nerve impairments themselves, they can carry over to your care. So I would look for an ENT to help from the medical standpoint. You can also work with a vestibular therapist. So they're a physical therapist who specializes in the ear and has specific balance training, because there's a lot that we can do from the therapy standpoint to help. And a lot of it's based on head movements, how you're moving, and really trying to use your other senses to help with your balance if the vestibular function is impaired.
Great, thank you. I know there is a vestibular organization, kind of like the Chordoma Foundation, where people can go and be able to find those vestibular therapists. So I think the kind of as a place to wrap up, there's a few questions about really knowing if the problems that you're having are from your chordoma surgery and what can be done about it. And I think, I think we would both want to just encourage everybody to, if you think there's something wrong, if you've noticed decreased strength, you're having balance issues, you're just not moving around like you used to seek out someone like Dr. Ruppert, a physiatrist, to see what can be done. And then again, if you're with Dr. Brown, you know, there was a time frame there of a year within after treatment is critical. But if you're not within that year, you can still, you know, find out if there might be any things that can help you. So I think the message is definitely talk with your Chordoma care team, ask for referrals, and evaluations will really be the way to find out what's out there for you. So I don't know, Dr. Ruppert, if you want to add anything to that.
Sure. It never hurts to ask. If you're experiencing something, it's kind of like the New York City subway station. If you see something, say something. It's the same thing. If you're experiencing something, please just say it. Let us know. Even if you don't know how to package your message, put the whatever out there, and we can figure it out. And that really kind of goes back to the beginning, where I said we have to do a thorough evaluation. We have to ask you what else you bring to the table, because it may be related to your chordoma, it may be completely unrelated. But it's our job to help figure that out and to make sure that we're pointing you in the right direction.
Awesome. Thank you. I think that's a great message to end with, that there's help available, so it never hurts to ask. Thank you. So I'm going to share my screen real quick because I want to let everybody know that we do have our final webinar of the conference series this year scheduled for November 10th at 11 a.m. So keep an eye out for, we'll be talking about coping with common emotional challenges like anxiety, fear, depression, and grief. So keep an eye on our website and Facebook page for announcements that registration is open for that. And a final thank you to our speakers. It was so great to have you. And thank you to all of us who joined us today. If you submitted a question that we did not get to, if there's anything else we can do to assist you, please contact us at support@chordoma.org. We're always here to help. So everyone take care, be well, and we'll see you for the final webinar in November.